Welcome to The Explainer. Today, we're zeroing in on a piece of medical tech that is, and I mean this literally, a lifeline for hundreds of thousands of people. We're talking about the tunneled dialysis catheter.
Okay, let's just start with a number that really tells the story. Over 80%. That's how many patients who start life-saving hemodialysis begin their journey with a catheter. It's a huge majority, and it really underscores just how critical this little device is, right from day one.
So you see, this isn't just some piece of plastic tubing. For so many people, it is the absolute essential bridge to survival. So today we're going to unpack exactly what it is, how it works, and how it's managed day to day.
So let's get right into the nitty-gritty. What exactly is this thing? This tunnel dialysis catheter, or as you'll often hear it called, a TDC.
Right, so unlike a simple IV you might get in the hospital for a couple of days, a TDC is built to last. And that word, tunneled, that's the key. It's actually passed under the skin for a short distance before it enters the vein. And there's this special cuff on the catheter that your own body tissue grows into, which does two amazing things. It anchors the catheter securely in place and creates a natural barrier against infection.
So why is it used? Well, think of it as a bridge. A lot of the time, that's its main job. When a patient needs dialysis right now, you can't wait weeks or even months for a more permanent access, like a fistula, which is a surgical connection between an artery and a vein, to be ready for use. The TDC gives you immediate, ready-to-go access. But, for some patients, because of their specific health situation, that bridge actually becomes their permanent solution.
Now, you might be thinking, a catheter is just a catheter, right? A simple tube. But as we're about to see, there is a surprising amount of clever engineering that goes into designing these things.
So no matter what they look like, all the different designs are chasing the exact same two goals. Goal number one, they have to move a lot of blood really fast to the dialysis machine for cleaning. Goal number two, they have to stop the just cleaned blood from getting immediately sucked right back into the machine. That's a problem called recirculation, and if it happens, the whole treatment becomes way less efficient.
And this is where it gets really interesting. You can see all the different ways engineers have tried to solve that flow problem. You've got split tips, where the tube separates into two, step tips, where one opening is a little longer than the other. You even have dual catheters, which are two completely separate lines. And then symmetric tips. Each one is just a different approach to solving the same basic physics puzzle.
And this quote, it really nails the current state of things. Researchers have studied all these designs. They've compared them in every way you can imagine. And the final verdict? Well, while one design might be a tiny bit better at one specific thing, no single design has come out as the clear, undisputed champion. So the choice often just comes down to what a doctor is comfortable with and what works best for a patient's own body.
Okay, so we know what it is, and we know there are different kinds. But how does this vital piece of gear actually get put in place? Let's walk through the procedure.
You know the saying, location, location, location? Well, for a TDC, the prime real estate is the right internal jugular vein in the neck. And why there? It's simple, really. It provides the most direct, straight-shot path for the catheter to get to the right side of the heart. That straight path means fewer chances for kinks or flow problems later on.
The procedure itself is, it's a carefully choreographed process. It all starts with using an ultrasound to safely guide a needle into the vein. No guesswork. Then, that tunnel is created from a small spot on the chest up to the neck. The catheter is gently fed through that tunnel and then inserted into the vein. And the whole time, a live X-ray, called fluoroscopy, is used to watch the catheter in real time to make sure its tip lands in the absolute perfect spot in the heart for the best possible flow.
Okay, so let's talk about the realities of living with a TDC. Because, like any medical device that stays in your body, it comes with potential risks. It's just really important to understand what those are.
You can really break these risks down into two big buckets. First, you have the immediate risks, things that could happen during or right after the placement procedure itself. Now, thanks to modern tools like ultrasound, these have become pretty rare. Then you have the second bucket, the long-term risks. These are the issues that can pop up after weeks, months, or even years of using the catheter.
So what are we talking about with those long-term challenges? The data points to three main culprits. First, you've got occlusion. That's just a blockage from a clot or other material, and it can happen to a lot of patients, up to 40%. Second, central venous stenosis, where the vein itself starts to get narrow around the catheter. And the third, and this is the most serious one, is the risk of infection. That can be anything from a minor skin issue to a life-threatening infection in the bloodstream.
But here's the good news. For these common long-term problems, medical teams aren't just crossing their fingers. They've developed a whole toolkit of effective ways to troubleshoot this lifeline and keep it working properly.
So let's tackle that most common issue head-on. What happens when the catheter just stops working, when it gets blocked? This is what's known as catheter occlusion.
Well, doctors have a few tricks up their sleeve. The first thing they usually try is a clot-busting drug that they can put right into the catheter to dissolve the blockage. If that doesn't work, or if the problem is this kind of fibrous sleeve that can form around the catheter, they can go in with a special tool to strip it away. And if all else fails, they can simply swap out the old catheter for a new one, using the exact same site.
All right, now for the complication that everyone rightly takes very seriously: infection. What's the game plan when bacteria show up where they don't belong?
How it's handled really depends on where the infection is and how bad it is. A small infection right at the exit site on the skin, that can often be knocked out with antibiotics. But if that infection gets into the tunnel under the skin, or even worse, into the bloodstream, well, that's a whole different ballgame. In those cases, the best and safest thing to do is often to remove the catheter right away, to get the source of the infection out of the body.
So when you take a step back, you realize this. The tunnel dialysis catheter is this incredible device that plays a crucial dual role. For so many, it's that temporary bridge that gets them started on treatment safely while they wait for something more permanent. But for a lot of other folks, it is the permanent lifeline they depend on, day in and day out, for survival. And that duality right there, it perfectly captures the constant challenge in dialysis care, that relentless search for reliable, safe, and long-lasting access to life-sustaining treatment.